Good afternoon, everybody, and welcome to the meeting hosted by the Behavioral Health Administration to talk about the Behavioral Health Administrative Service Organizations. My name is Summer Gathercole. I am the Deputy Commissioner of Operations for the Behavioral Health Administration, and I go by she, her, hers. A couple of groundkeeping rules before we jump in, just to let everyone know, hopefully you did hear that this session is being recorded. We will be posting the recording and the deck on our website early next week. Everyone is muted upon joining the meeting. We do ask that you keep yourself on mute just to be able to minimize the background noise. And we would love to see your smiling faces. So definitely encourage you to keep your video on. We have a large number of people who are going to be joining this meeting today. So we want to ask all of you to submit your questions via the chat box. We will do our best to answer all of the questions that we can. Given how much content we have to cover today, we will likely not get to everyone's questions when we get to the appropriate break to answer those questions. We will do our best to identify what themes of questions we have and add them to our frequently asked questions page, which we will share the link with you here in the chat in a few minutes. If we go to the next slide, as I said, we are going to be talking and giving an update on the Behavioral Health Administrative Service Organization, as well as care coordination. So we have a couple of topics to cover today. As most of you know, there has been a lot of conversations and a lot of work over the last couple of months around the administrative service organizations and care coordination. So we want to share the latest updates with all of you. But before we do that, I want to turn things over to our fearless leader, our commissioner, Dr. Medlock.
Thank you, Summer, and good afternoon, people of Colorado. It's fantastic to be in community with you today. My name is Morgan Medlock, she, her, hers. I'm the commissioner of the Behavioral Health Administration. And on the next slide, we just like to get anchored in our purpose, which is so much larger than just defining regions for the Behavioral Health Administrative Service Organizations. This is really a conversation about the fact that the people of Colorado deserve to experience whole person health. And as we think about the whole person, it does involve access to behavioral health, but it also includes physical health, mental health, and substance use supports and services. And so this is much bigger for us than just a meeting about a specific topic. For us, it's about co-creating a people-first behavioral health system that truly meets the needs of every person in Colorado. On the next slide, for those who are new to the BHA, which just launched 6 months ago, we want you to know that we are committed to these values on screen. In fact, we hope to conduct this meeting in alignment with these values. Our first value is truth, which means being transparent and accurate when addressing you as the people of Colorado. Our next value is equity, including naming root causes of injustices and allocating resources to support the desired outcomes. We think about community-informed practice and hope to exemplify that today as we seek your input on how we design a care coordination system and a system for regional service delivery of quality services. We also want to work in a collaborative nature, working in partnership to realize a holistic behavioral health vision. And finally, we think about generational impact. So this conversation is meant to not just be impactful right now for Colorado, but to be meaningful 3 generations from now. And so on the next slide, as we begin this meeting, we actually want to think about what difference does this make for us, for our neighbors, for our friends, for our family members. You know, at the BHA, we talk a lot about not just building a system that's accessible, meaningful, and trusted for the people of Colorado, but one that we would want our own family members to be a part of. So as you hear the presentation today from both Deputy Commissioner Gathercole and Health Management Associates, we ask you to think about what difference does this make for you, for your family, for your loved ones, and for the people that you serve if you're a provider on the call today. We fundamentally believe in and advocate for every person in Colorado to have comprehensive, effective, and equitable care across their lifespan, and to have the supports that they need when, where, and how they need it. So we encourage you to bring your full self to this conversation. We don't mind being challenged. Our core value is truth. And again, we want to welcome you to the forum today. In closing, and as I pass back to Summer, I want to invite our support team to please post our inaugural strategic plan in the chat. And we want every participant to know that that plan was released this week, and it is our 3-year vision for how we continue to partner on building a people-first system. Thank you.
Thank you, Dr. Medlock. And if we go to the next slide, we'll give you a snapshot of our agenda today. As you will hear, we're going to do a deep dive into behavioral health administrative service organizations. We'll have some time for Q&A at the end of that presentation. Then we will move into care coordination and also have a few minutes of Q&A. As I said in the beginning, for those of you who might have joined afterward, we will do our best to try to address the questions that are in the chat box. Definitely encourage you to include your thoughts, your reactions, your questions in the chat box. We may not be able to get to all of the questions during the Q&A period, and we will gather the themes from the questions and be sure to update our frequently asked questions document, which is also on our webpage. With that, let's move right into it. And we're going to start with talking about behavioral health, the administrative service organizations. We go to the next slide. And what are they? For those of you who may not be living and breathing this every single day, let's just kind of take a step back and talk broader for a moment about administrative service organizations. We have done a ton of work and research over the last couple of years, talking with different states who have administrative service organizations, understanding their model, understanding the lessons that they learned. And what I will share with you is that there is no one size fits all. Every state has a different model. There are many states that have administrative service organizations, and ASOs, as we refer to them, really are experts in the management of behavioral health systems. So really looking at that we were getting resources to priority populations, ensuring that there's quality care, balancing the costs. I think one of the big takeaways that I would want to make sure that everybody knows is that ASOs operate on behalf of the state. So they are representing the state. And yet, I want to make sure everybody also knows that policy and oversight remains at the state level. So the state, in this case, Colorado, is accountable for ensuring that the ASO is meeting requirements and expectations. As some of you know, accountability is one of the 6 pillars that was identified by the Behavioral Health Task Force. We have been working and will continue to work very hard to ensure that there's strong accountability in place. That was one of the biggest requests that we've heard from our partners and our stakeholders over the last couple of years, and we will continue to make sure that we are committed to that. If we go to the next slide. All right, so just to tell you a little bit about, here's what is in statute. This past session, 2022, I guess last year, we established the newly proposed safety net system that creates behavioral health administrative service organizations. We refer to them fondly as BHASOs. Those BHASOs must be established by statute no later than July 1st of 2024. They must accept and provide behavioral health safety net services to individuals outside of their own region. So I really want to make sure if there's anything that you take away from this slide, it is that BHASOs must accept and work with people across different regions. No one will be turned away because they live in a different region. BHASOs will operate on a regional basis. There will be multiple BHASOs as outlined in statute, and entities will participate in a competitive process to become a BHASO. There's no kind of pre-selection or predetermination of who is going to be a BHASO. I expect that we will have a highly competitive process. We'll talk more about the duties and responsibilities of the BHASOs in a few minutes. But if we go to the next slide, I want to give you a quick overview of our current system versus the system that we're moving towards. So the current system is what you see there on the left-hand side of the screen. We have currently the Behavioral Health Administration that works with community mental health centers that provides mental health services and other services, of course. We contract with administrative service organizations currently that provide crisis provider services. We also contract with managed service organizations, not to add too many acronyms to the conversation today. And those MSOs provide substance use disorder services. The ASOs and the MSOs contract with providers. And what I would point out is that this is currently the programs and funding that's overseen by the Behavioral Health Administration. This does not reflect Medicaid, and it does not reflect programs across our executive branch that also contract with providers. So one of the biggest findings, I think, that the Governor's Behavioral Health Task Force found in 2019 and 2020 is that we have a very fragmented system. So that is one of the recommendations for moving towards having not only just the Behavioral Health Administration, but also having regional entities. And that's what you see there on the right hand of your screen. The Behavioral Health Administration will be contracting with Behavioral Health Administrative Service Organizations, otherwise known as BHASOs. Those BHASOs are responsible for building out a network of safety net providers and it can to address the continuum of care. And the intent is to make sure that it's easier for people in Colorado to access services because the BHASOs will be establishing a full network across the continuum. I also want to point out, because we've heard quite a bit around administrative burden, this structure will also make it easier for providers who will have less contracts to manage and thus will be able to spend more time focused on patient care. If we go to the next slide, I'll tell you just quickly some of the functions of what the BHASOs will be doing. One is that you see here that the BHASOs will be helping people initiate behavioral health care. BHASOs will also be serving as navigators, or will have navigators on their staff. And we'll talk about that much more in our conversation around care coordination. BHASOs will consolidate the services that are currently offered by our MSOs, ASOs, and community mental health centers. So again, really addressing the bifurcation of services and consolidating mental health, crisis, and substance use disorder services within one network. BHASOs will build a continuum of behavioral health safety net services and ensure that there's an adequate network in the region and across their full region. And BHASOs will also interface and align with the RAIs, the regional accountable entities that manage services and provide care coordination for Medicaid members. So that's a high-level overview. If we go to the next slide, I mentioned earlier that we have done a ton of work over the last couple of months in terms of hearing from stakeholders, thinking about how do we want to approach making decisions on what do the regions look like for the BHASOs, and how do we best serve people in Colorado? Because I think we can all agree that's really what this comes down to. We have been fortunate to be working with a team from Health Management Associates over the past 6 or 7 months. They have helped to facilitate numerous stakeholder sessions. They have analyzed data, and they have helped us begin to identify some solutions for what is going to be best for people in Colorado. So we want to have you hear from them directly about their work and their findings. And so with that, I'm going to hand things over to Angie Bergerford, one of the managing principals at Health Management Associates. Angie, take it away.
Thank you so much, Summer. And I will have to say that we feel that we have been very fortunate over the past year, many months to be able to support the work of the BHA, as well as support all of you in this huge transformational effort. So thank you for including us in the conversation today. So I think my task is to describe briefly the stakeholder engagement process, as well as walk through the analysis that the BHA has asked us to perform related to the regional approach for the BHASOs. So we can just go ahead and jump right in to the next slide. So I want to describe a little bit the stakeholder process. And we were so fortunate to have such good stakeholder turnout and very thoughtful and very constructive feedback from many of you on the call this afternoon. So we did have a series, 26 stakeholder engagement sessions. Those occurred primarily in September and October. In October, we released a survey to be able to gather additional stakeholder feedback from those that perhaps weren't able to participate in those 26 sessions. And I want to kind of step back and indicate, you can see here on this slide the wide set of stakeholder groups that we talked to, including tribes, BIPOC, those with disabilities, people with serious mental illness. And we just, are so thankful for that participation, as well as, talking to the RAIs and the community mental health centers and other providers as well. We've got a vast participation in the survey that was released. We left that open for a month to gather additional feedback, and then also spent several weeks getting feedback across the state agencies, talking to members of the executive branch, talking to counties, talking to the BHA Advisory Council. So we continued those conversations well into this new year. So I just wanted to spend a moment acknowledging that and all of your participation that really is informing what you're going to be seeing over the next several slides, or actually throughout the conversation today. Okay, next slide. So wanted to share a little bit of the feedback prior to jumping into the analysis. So the stakeholders were very clear around some general themes related to the BHASOs. So they wanted to be able to ensure that the BHASOs were providing consistent and available services. They wanted to see flexibility of where services were able to be accessed and based on the person's choice. And really, the person's choice was a theme that, surrounded every single conversation we had. And then again, the BHASO is providing administrative oversight and monitoring. While there certainly is that functionality related to accountability, that should not become a barrier to access to services. So keeping that in mind throughout the conversations. There was specific feedback on the regions. So they really wanted to see fewer regions rather than more. And they made it very, very clear that they did not want to split the RAE regions into, the different BHASO regions. So really wanted to be able to kind of maintain in the configuration the RAE regions and not have them split. They also felt that it was important that there be alignment between the intermediaries, across the intermediaries, to support the continuum of care and specifically care coordination efforts. And the providers really were interested in making sure that there was efficiency and streamlining and that we weren't adding to their administrative burden by having to contract with many, many different entities moving forward. And also acknowledging, stakeholder experience with other regional structures and making sure that we were being cognizant of geography and the availability of services to be able to meet those individual needs, particularly in the rural and frontier areas. Okay, next slide. So background and purpose, and really we wanted to be able to focus on two key areas at the direction of the BHA. One was making sure that the regional structure ensured equity of services in each region, and also it was structured in a way to maximize funding for services. And we'll kind of loop back around to both of those things. We also wanted to make sure that in the analysis, we were being balanced across the region in terms of the demographics, the behavioral health needs, and behavioral health service utilization. So those were really key things that we needed to keep in mind in designing the analysis. And then we also wanted to make sure that we were looking across a variety of different elements to determine, what those regions needed to look like. So next slide, please. So here is where you can see the different scenarios that are associated with an approach that contains two BHASO regions. So we'll walk through these so that you can see, and kind of this will tee up what you're going to be seeing in the next several slides, that we are focusing these next several slides on the notion of having two BHASOs. So, but we are looking at it from three different configurations, if you will. So we have one scenario that has a BHASO made up of RAE regions 1, 2, 5, and 6. And then a second BHASO that's made up of RAE regions 3, 4, and 7. And then you can see in scenario 2, we have BHASO 1 in the blue that's made up of RAE regions 3, 5, and 6. And then BHASO 2 is made up of regions 1, 2, 4, and 7. And then scenario 3 is just a little variation on region 2 that then also scoops in Park, Teller, and El Paso into that configuration. So these are going to be the regions and kind of the scenarios that we're going to get into in the next several slides. Next slide, please. So kind of looping back now that you've seen the two region approach and informing, and focusing in on data and the feedback through the focus groups and other conversations, we heard that fewer regions really would minimize the administrative burden, particularly for providers who have to contract, bill, and coordinate care of their individuals. So that really did line up with what we're hearing from the stakeholders. So that's why you see the 2 regions suggested. Also, by having 2 regions, less dollars are spent on administrative costs, allowing more dollars to go to direct services within the behavioral health system. Again, something that we heard loud and clear through the stakeholder engagement. There's also more opportunity to align services across the regions and with the RAIs. So, our thought is, and the approach we took, the more subdivisions and the more discrete regions that you have, that gets compounded. And then really that offers potentially more areas for folks to fall through the cracks. So wanting to really make sure that we had, solid alignment and fewer opportunities for people to get lost in the mix. And then also the regional advisory committees will work with the assigned BHASO in their region, and they wouldn't have to report to multiple BHASOs across several regions. Again, in the spirit of wanting to be efficient, be clear, and not confusing in terms of who is responsible. So just wanted to provide a little bit of additional background related to that as well. Okay, next slide. So kind of dipping into the specific analysis, and wanted to provide a little bit of framing around what we looked at. So we actually looked at 28 different factors. And for those of you who are familiar with the behavioral health needs assessment that was performed in 2020, these factors will look very similar. So we wanted to use data that folks were familiar with and that was already existing that we could use for the analysis to be able to build out proposed regions. So we broke those 28 factors out and into domains, and we looked at geography. We looked at a number of factors related to population demographics. We looked at behavioral health need, as well as Medicaid utilization. We looked at the continuum of behavioral health services, the provider network, as well as healthcare utilization. And we'll drop into a little bit more detail on that in a minute, but really wanted to be able to compare those configurations and scenarios and be able to really come up with a suggestion in terms of how we could balance and ensure equity across services in those regions and a balanced demographic across the 2 BHASOs. And again, want to highlight that we really wanted to make sure that there was no RAI that was split in any of our scenarios. Okay, next slide. So I know that this is very busy, and it's kind of hard to look at, but wanted to be able to share with all of you the specific things that were included in our analysis. So, going from top to bottom, we looked at geography. So we looked at the number of counties and wanted to make sure that we were balancing in a way that made sense with the number of counties. And then really wanted to make sure we understood and were accommodating demographics. So we wanted to look, at where the statewide population is and make sure we were balanced there, but really wanted to understand the people in each age group. We wanted to understand the BIPOC population. We wanted to understand those with serious mental illness. We wanted to understand the population below 300% of poverty level and where they were living. So those were the types of demographics that we incorporated into the analysis. And then we also wanted to focus on behavioral health needs. So you can see here the factors 9 through 15, where we focused on the adult population with poor mental health. We looked at it from both the state and regional perspective. We looked at the state safety net population in urban communities and rural, just to give you a flavor, and then also looking at the number of counties that exceeded the state suicide rate, as well as exceeded the state drug overdose rate, to be able to gauge the behavioral health need in the regions. It was important to also look at Medicaid utilization and understand the folks, the Medicaid members, as a percent of the statewide population. We also wanted to look at the percent of members with a mental health diagnosis, that have received at least one mental health service within the year, as well as the percent of Medicaid members with an SUD diagnosis who also received at least one SUD service. So really wanted to dig into the utilization when we were contemplating the analysis and what those regions need to look like. As well as looking at the provider network, we really want to make sure we understand where providers are who are billing and providing behavioral health services, and where there are where CMHC providers are located, as well as looking at the average number of behavioral health services across the continuum and healthcare utilization from the perspective of number of behavioral health related ED visits and so on. So you can see that we looked at a number of factors as part of the analysis. And one thing that to note here that you'll see in the narrative is that scenario one, which was kind of that crescent shaped approach where you had one in the green that addressed that was responsible for that lower right hand corner of the state, and the other that kind of swooped up around the western slope and across the state. That scenario number one, really did result in the most balanced kind of approach across all of these factors, and that's where you can see kind of that tallied the most check marks in terms of understanding the distribution of the factors and that better alignment between the two regions. And hopefully I haven't lost anybody at this point, because now we're starting to get into the good stuff, but kind of illustrating some of these factors for you. So next slide. Okay, so we're not going to go through every single factor, all 28 of them, but wanted just to give you a flavor of the factors and kind of the level of analysis and what they looked like. So this is a representation of the percent and number of BIPOC living in Colorado. The top percent or the top chart shows each of the scenarios. And the percent and number living in Colorado, generally speaking, and how it breaks out across those regions. The chart below is the same analysis, but it's the percent within the regional, the regions that we are looking at. So this is really important to make sure that we have crafted this in a way where that population is specifically focused on, given challenges related to equity and disparities, and making sure that population is balanced across the regions to make sure that both of those BHASOs are able to pay attention and fully make accommodations and make sure that this particular population is paid attention to. We didn't want to develop regions in a way that one BHASO would be solely responsible. So really wanting to make sure that there was a balance given the importance of serving this population well. Okay, next slide. So again, this is another illustration related to Colorado's adult population with poor mental health, and looking at the percentage of adults with poor mental health, all adults within the region as compared to overall. Again, this is another indicator that we felt was important to make sure that we had the population evenly distributed, so each BHASO would be able to focus on this particular population. It's important that we included this from our perspective because this is an important indicator of health need. It's also a risk factor for crisis events if needs are not met. So you can see in this scenario that we do have, population pretty evenly spread between both of those regions in scenario one. And then you can see how it kind of varies when you start looking at those different configurations of regions in scenario two and scenario three, where, for example, you go from a 51-49% split to something in scenarios three, where BHASO 1 has 70% of that population compared to BHASO 2 that only has 30%. Next slide. We wanted to also make sure that we included an example in the presentation today that looked at providers and where providers were. So this chart illustrates the number of Medicaid providers who are billing behavioral health services. This is important to kind of keep in mind because it's a proxy for kind of gauging access to care. For example, making sure that there are a sufficient number of providers to be able to serve the population, that we have those evenly distributed, that there is the appropriate expertise to serve the individuals in need of care. It's also an indicator of choice. And making sure that we do have sufficient providers in each of those regions to ensure individuals are able to choose their provider. So as you can see here, in scenario 1, there is a better distribution, if you will, between BHASO 1 and BHASO 2, again, as compared to scenario 2 and scenario 3. In each of these, it does look like BHASO 1 has a little bit more in terms of the number of those providers currently, but it's a much better scenario. The split is not as large as in scenario 2 and scenario 3. Next slide. So hopefully we've been able to kind of give you a flavor of the analysis and what that 2-region approach looks like, and how we compared different scenarios or different configuration of regions to kind of make sure we were honing in a way that made sense across equity of services, making sure we had the demographics honed in on, making sure we were looking at behavioral health need, service utilization. But we also heard, as part of our stakeholder engagement, why don't you think about, just going with 1 region, or what, 2 seems like a little too few. Would you consider adding or looking at additional regions other than the 2? So, in thinking about the 1 region model, there is a statutory requirement that there be regions. Not able to move at this juncture, with that 1 region model, given the statute. But we also wanted to be responsive to those who suggested additional regions. So you can see here there is an alternative 3-region model that could potentially be a viable option while really maintaining those goals and objectives that I mentioned earlier. Wanting to ensure the equity of services in each region, maximize funding of services. We want to, continue to focus on a balance of demographics, behavioral health need, and behavioral health service utilization in those regions. And then we also want to keep in mind that we want to minimize administrative burden for providers related to contracting and billing, and being able to coordinate efficiently and effectively the care for the individuals they're serving. So we still, are keeping these things top of mind, but wanted to share an alternative. And you can see here that the BHASO 1 region is made up of RAY 1 and 6. BHASO 2 is made up of RAY regions 2, 4, and 7. And then there is now a 3rd made up of RAY regions 3 and 5. Next slide, please. Oh, and I guess now it's time to turn it over to Summer. So thank you, Summer. I think you're up.
Thank you, Angie. Thanks for taking the time to walk through and giving us a couple of examples of how we've analyzed some of the data. Really appreciate you and your team. One of the other things that we wanted to touch base upon is the regional subcommittees. Statute directs the BHA to create at least 1 regional subcommittee for each BHASO region. What we've heard, especially now that you all have seen the different scenarios under consideration, is that some of those regions are a little too large to have just 1 regional subcommittee. So, and just to be clear, the regional subcommittees are really responsible for providing kind of input and feedback to the BHASO on what's working well, what their emerging needs are that they are seeing in the community, and how we can work together more closely. I just want to make sure everyone knows that BHASOs will be encouraged to establish additional subcommittees to ensure that they are working in partnership across all of the various communities in their regions. So we're not trying to limit to one subcommittee per region. I also want to make sure that everyone knows that BHASOs will also be working with existing local advisory committees. Some of your communities already have advisory committees. We want to make sure that the BHASOs are connecting with those groups. The other thing I want to make sure everyone knows is that per statute, BHASOs are required to submit an annual stakeholder input report. This works in a couple of different ways. BHASOs are required to share what they have heard over the past year and what they have done about what they have heard. They're also required to share what they've heard most recently, what the emerging needs are in the communities that they're working with, and also what they're planning to do to meet those emerging needs or any factors that have come to their attention. So I wanted to make sure that we touched upon the regional subcommittees, because I do know that there is quite a bit of interest in ensuring that we commit to our pillar of local and lived expertise guidance moving forward. So with that, we go to the next slide. Before we open it up for questions, I did see a couple of things that I wanted to just address quickly. I want to reiterate what we said at the beginning. The slides from this presentation and the recording will be on our webpage early next week. So definitely encourage you to go back to that and take a look, given how much information we are covering today. I know there's been a couple of questions around the RFP and what details we can share around that. At this time, I can tell you that an RFP for the BHASOs will be released in the early spring. Procurement rules do not allow me to share any other details. We have very, very strict rules around it, so we're not really able to answer any other details around the RFP at this time, except that you can expect to see it later on this spring. And I know that there were some questions too around the funding and how that works. So I think the most important thing for you to know from the data that we just shared is that, one, we're trying to find the scenario that provides the most equitable funding for all people across Colorado. And that's really part of the reason for the deep dive analysis and looking at all of those different factors. The other takeaway is that people in one BHASO region can go to services in another BHASO region, and that is something that is allowed. We are encouraging it. Is not going to be a problem at all. So I want to make sure that people heard that. Dr. Medlock, I want to turn it over to you for a minute or two to respond to some of the other questions that have come up.
Thank you so much. I was trying to keep up. I think there's a remaining question about just the principles of what it means to be a safety net and what do we mean by not rejecting patients and truly having a no wrong door approach to our system. And so just want to reiterate that the Behavioral Health Administration is committed to House Bill 1278 that states that, a true safety net should have an open door approach, meaning that individuals cannot be denied care based on the intensity of their need, based on behavior that may be a byproduct of having a behavioral health need, based on exiting the criminal justice system, or based on exiting an inpatient psychiatric facility or having competency needs. So those are the principles within House Bill 1278, and we are committed to that. Marina, are there other questions that I missed in the chat that I need to address at this time?
Yes, there are a few, and let me read the first one too. The question says, I'm concerned that Elbert County being lumped in with Arapahoe and Adams County as it's rural and little to no services.
Thank you so much for that. And so one of the things that we have to acknowledge in this conversation is that our current model for how intermediaries work generally have us thinking in terms of a framework that services are limited by location. So just to support what Summer has said today, this model is actually not limited based on what county you dwell in. You can actually move from one BHASO to the other in terms of where services are available. So that is the model we are promoting here. So want to just clarify that. What's the next question?
Thank you. Next question. The problem with having CMHCs provide services to people with most severe MI is they are the default, as that they currently have the ability to kick people out or to make services so horrible clients leave. We need to have choice for people with all kinds of disabilities and have anyone designated a safety net, have no eject, no reject policy, and strict oversight about retaliation.
Thank you for that. I think this is related to a couple of issues. One, we do want to clarify that the BHA is responsible for having a system-wide grievance resolution process that is established by July 1, 2024. However, we have gotten an early start, and in partnership with Healthcare Policy and Finance, as well as our other state agency partners, we have drafted an initial approach to grievance resolution so that when people don't get the care that they deserve, that we can step in and ensure their system accountability. The other piece to that in terms of who is providing services, I think that's what was some of the dialogue in the chat. That piece is a little bit beyond the conversation today. However, I will say that one of the key reforms that we are embarking upon in Colorado is the notion that our system can be supported with both comprehensive and essential safety net providers. And so comprehensive providers are obviously larger entities. However, we're making room in our regulatory structure for essential providers. Those are providers who may just focus on care coordination. Those are providers who may just focus, for instance, on crisis services, or may just focus on a certain type of outpatient services. So we do want to clarify that, whereas the comprehensive providers do more beyond that, high intensity services and so on. So we want to clarify that the overall vision is to have everybody at the table. Frankly, we need providers that can do the comprehensive approach, and we also need providers that can be more focused, including providing integrated care in physical health settings. I hope that helps.
Thank you. I have a few more questions. Summer, are we okay on time?
We are good.
Okay,
Thank you.
great. Next question. Do you have graphs or tables for the 3 BHASO scenario that we can share?
We apologize. We did move through the slides quickly. Going to ask our support team if you would kindly just put in the chat the PowerPoint that I shared with the advisory council that shows the 3 scenarios in that slide set. And I think for the participants today, if you click on that link, once it's pasted and start at slide 13, you should then see the different scenarios there. So that's all on our website in terms of those slides.
Thank you. Next question. Are we able to address questions in regards to the updated M1 standards during this meeting?
Thank you so much. That's a great question. Our Quality and Standards Division actually just completed extensive stakeholdering on our rule rewrite process, although this question is related, it sounds like, to House Bill 1256 around changes to emergency mental health holds. That is a topic that's slightly beyond this one, but I'm going to ask would our policy director and would our Quality and Standards Director kindly put your contact information in the chat so that that participant can follow up with you.
Thank you. Next comment, and this is a comment, not a question. Folks in Elbert cannot get to other regions, and getting to even Parker is about a 45-minute drive.
We do appreciate that. One of the things that we are hoping to resolve and negotiate in our RFP process is to think about how can we support innovation at the BHASO level. Obviously, we don't expect the people of Colorado to simply resolve system gaps by driving further, and we understand that. So that is going to be part of our negotiation process as we think about the best approach to negotiating for the establishment of the BHASOs by 2024.
Thank you. Next question. Can you tell us what advisory committees may represent, for example, residents of Denver?
So the House Bill 1278 that established the Behavioral Health Administration and its duties does currently define who may sit on a regional subcommittee, and the BHA is in favor of expanding those seats, but currently the 5 seats are defined as a county commissioner, a person with lived experience, and there are other types of community members that are described there. So I consider that the minimum of who needs to be involved. we're certainly interested in expanding community voice, but that's how it's currently articulated in House Bill 1278.
Summer, am I okay to keep going?
We've probably got time for about 2 more questions.
Okay, next question. I'm also interested in how the BHA works with the public school system.
That's fantastic. So we started out by linking in our initial draft of our strategic plan, our inaugural strategic plan, I should say, through 2025. You'll notice at the end of that plan, what we call the roadmap to reform. One of our key pieces is creating a new system norm of investing in upstream prevention. And as we talk about what that really means, we talk about expanding to generational supports, expanding early childhood mental health supports, and school-based supports. So absolutely, this is part of our vision, and we look forward to co-creating solutions with you.
Thank you. And the last one, and this is a comment, funding will be hindered greatly for that region if being considered equal to the urban areas, and clients cannot just drive to another region due to lack of services in their region.
We appreciate that, and that's why we are so much leaning into the data argument for how we define these regions, that we're not just simply sending dollars to where there are more people or more services, but we're sending dollars down to the appropriate regions based on the population needs there. And so that's why we spent so much time today on data, not simply wanting to send dollars to where there may already be resources, but sending dollars where there's a need. That's how we define equity.
Thank you, Dr. Medlock. Summer, back to you.
Thanks.
Thank you both very much, and I appreciate all the questions. I'm sorry that we did not get to all of them, but we will definitely look at themes from the questions and do our best to update our frequently asked questions page on our website. I think we have a poll, and I want to see, Matt, if you're able to launch that poll real quickly before we move into the next section. All right, so this is a true/false poll. The question here: BHASOs must accept and provide behavioral health safety net services to individuals outside of their own region. Tell us if that's true or false.
No.
All right, why don't we end the poll? We've got about 190 responses so far. And the results, this is true. 90% of you got this right. BHASOs must accept and provide behavioral health safety net services to people outside of their own region. So people can and should feel comfortable going back and forth between different BHASO regions and know that they will get services. So we wanted to make sure that we drove that point home, and I'm glad that we could bring it home again. All right, we are going to move in our agenda right now to talking about care coordination. We go to the next slide. And if we actually go to the next slide, I want to talk a little bit. I'm going to take us back in history. I'm going to take us back to August 2020. It was the last meeting of the Governor's Behavioral Health Task Force. Up until this meeting, over the course of a couple of meetings, we had had a series of vigorous conversations around care coordination. And I know this screen in particular is very text heavy, so I'm going to call out some of the key points to take away from this, but wanted to share with you the final vote from the Behavioral Health Task Force when it comes to care coordination. So the task force voted to establish a structure for regional support that offers care coordination and management to help clients and families initiate care and navigate to the right supports. The structures will coordinate care and collaborate with local communities and help clients and families who are using or relying on publicly funded services. The structures will exist regionally or be reflective of populations and geography, with standards established by the BHA and customized to the local community. The structures will also have an advisory board composed of people with lived experience, local government officials, and other stakeholders to provide guidance on the needs of community residents and how to meet those needs. I also want to point out the structures are not expected to coordinate traditional care for Coloradans receiving behavioral health through commercial and/or Medicaid payers. So I wanted to take us back in that moment of time just to remind everybody of where we landed with the Behavioral Health Task Force and their final vote for approval. If we go to the next slide, I want to talk a little bit about the work that's been done since that vote in the Behavioral Health Task Force. In 2021, we worked with a group of about 70 to 80 everyday Coloradans to tell us what kind of experience they wanted to have when they interact with care coordination or have access to care coordination in Colorado. It was a group that really worked at a high level. I'll share with you what they told us that successful care coordination would be. They said it needs to be person-centered. They want compassionate, human, and trustworthy care coordination. They want care coordination that is culturally relevant and respectful of others, regardless of the background, belief, or ability. They want care coordination that's trauma-informed. They want care coordination that is timely, coordinated, and supported at all levels and across all systems. And finally, they want care coordination that is accountable. The final recommendation that came out of this group in 2021, and really this was a group, again, of people from all across Colorado who had intersected with the behavioral health system in one way or another, either personally or because of one of their loved ones. The final recommendation coming out of this group in 2021 was to create a centralized system where people could learn about and access services, both specific to behavioral health and also broader and around social and economic needs. This group kind of kept everything at a very high level, so they didn't get into a lot of details in terms of how would all of that come to be. And what you see here on the screen is actually the next step. So we had a group in 2021 that provided those initial recommendations and also included recommendations around regional connection centers and multi-system integration, again, at a very high level. In 2022, we formed this care coordination policy work group. Again, this engaged people and partners across the state, some of our stakeholders, to really help us design the policy and the technology infrastructure that's needed for statewide care coordination. The recommendations coming from this group included 3 levels of care coordination, which is how we really landed on the care coordination pieces that we're going to share with you today. They had system integration grounded in care coordination and wanted services provided at the local and community level. If we go to the next slide, I'll tell you about some of the recommendations that came out of this care coordination policy work group. One recommendation is that the BHASOs have navigators. So the recommendation was that navigators who are employed by the BHASOs should be responsible for referring and connecting people to behavioral health providers and other community-based services, really making sure that they understand the person and the family's priorities and preferences, helping people to understand the best care coordination options available. And I think probably almost most importantly, referring and facilitating a warm handoff to ensure that connections are made. So that means not just giving somebody a list of 10 phone numbers to call and wishing them luck, actually making sure that there's a warm handoff between the person and the connection to the resource. I'll point out that in this particular report, the BHASOs are referred to as regional connection centers, but the premise is still the same, that BHASOs would employ navigators to refer and connect people to the services that they need. On the right-hand side of the screen, you'll see the recommendations around care coordination entities that are be responsible for providing wraparound services for people who are involved with multiple systems to really facilitate a shared plan by the care team. These could be existing care coordination entities, as we know that some communities have these across the state. These could be providers. These are numerous types of entities that could fall under care coordination entities. I would also point out, apologies, going back to navigators real quickly, Senate Bill 22-177 also charges BHASOs to use navigators to support people and connect them to behavioral health and other services. If we go to the next slide. I wanted to share a little bit about the feedback that we heard from stakeholders around care coordination, specifically over the last 9 to 12 months. People asked and stakeholders asked that definitions of care coordination be very clear, and that if we have different levels of care coordination, that we're really clear about what is included in that. There's a preference for care coordination to be done at the point of service and certainly within the person's community. They want, there was a request for inclusivity of behavioral health and physical health needs, and make sure that we are also looking at how to address the social determinants of health. Stakeholders also for multiple approaches to accessing care coordination, with an array of entry points and places where care coordination could occur. So that could be online, that could be in person, in an office, in a community, et cetera. Stakeholders also asked that we utilize and leverage existing care coordination infrastructure. So let's not duplicate things that already exist. Let's support what we know is working in local communities. Stakeholders asked for care coordination to have a technology infrastructure to support care coordination in warm handoffs. And finally, people asked that care coordinators be well-trained and knowledgeable of the local resources. So we really heard loud and clear that people didn't want to call, people who live in rural and frontier areas did not want to call someone on the Front Range and have the Front Range try to tell them how to access services in their local community. So I wanted to share a little bit of that feedback that we've heard over the last 9 to 12 months. If we go to the next slide. I also wanted to share with you some research that we did around the key components of successful care coordination in behavioral health. So this is some work that we had health management associates do for us in 2021, again, coming out of the behavioral health task force and the numerous conversations we had around care coordination and the questions. We wanted to understand what are some of the best practices for care coordination as other states have been successful in doing this. So a couple of key components here. Care coordination is best when operationalized and customized to the local community. Multiple channels are used to identify and engage people in care coordination. So again, embracing that no wrong door policy. And finally, partnerships are key and require shared understanding of care coordination, which is why it's so important to ensure that our BHASOs are building out a network of providers that are working together across the continuum. If we go to the next slide, I want to just tell you real quickly what's in statute around care coordination, especially when it's in relation to BHASOs. BHASOs have the responsibility of providing care coordination services, whether directly or through contract with behavioral health safety net providers. The BHA, we are responsible for establishing a variety of processes, especially coordination between BHASOs and other care coordination entities. We're responsible for establishing processes for referrals between entities. And we're also responsible for ensuring that there are processes for efficient and person-centered care coordination for people who have acute and complex needs. So I wanted to just make sure that we touched upon what's in statute, and so you know what the law says. If we go to the next slide. Before we kind of jump into what's the definition of care coordination, I wanted to talk to you a little bit about our safety net providers. Thank you. Appreciate you putting that person on mute. Okay, in rule, we have outlined comprehensive community behavioral health providers, and it's important to understand the definition of what these providers are and what they do starting in July of 2024, because you'll hear about the levels of care coordination that they'll be providing here in a few minutes. So comprehensive community behavioral health providers provide all of the services that you see listed there on the bullets: emergency and crisis services, outpatient services, high intensity outpatient services, recovery supports, outpatient competency restoration, outreach, education and engagement, care management and care coordination, screening, assessment, and diagnosis. Under our new safety net system, we will also have essential safety net providers who must offer at least one of these services. So I just want to make sure everyone's really clear on the difference between the comprehensive community behavioral health providers who must offer all of these services and essential safety net providers who must offer at least one of these services. If we go to the next slide, I want to share with you the proposed definition for care coordination. This definition that you see here at the very top of your screen actually came directly from the Care Coordination Policy Work Group. It's care coordination is person-centered, trauma-informed, and culturally responsive activities that support support people in accessing and engaging in the physical health, behavioral health, and social services needed to achieve whole person health. I will just point out that that definition again came from the Care Coordination Policy Work Group. We did change one thing, which was changing from the end to achieve whole person health. They had suggested to achieve to achieve well-being. And so we just wanted to make sure that there was alignment with our pillars. As I said earlier, the Care Coordination Policy Work Group really did outline 3 levels of care coordination that they wanted to see under this definition. And finally, what I would say is that based on feedback that we have gotten from our partners here within the Behavioral Health Administration, we also wanted to highlight that care coordination activities include deliberately organizing individual care activities and timely sharing of information among all the participants concerned with the person's care. So let's jump into what does all of this mean? If we go to the next slide, proposed level 1 care coordination. This is really about offering the basic. It addresses the straightforward needs to help navigate the complexities of our system and make sure that people are connected and have that warm handoff to different services. If we go to the next slide, this here just provides a list of what we anticipate the services being under level 1 care coordination. To summarize, I would say that level 1 care coordination services include screening and triage, really focusing on person-centered advocacy, health education, developing immediate plans of action, and care transitions. In terms of who can offer care coordination level 1 services, this can be offered by comprehensive community behavioral health providers. This can be offered by essential providers, those who are in the independent provider network, and could also even be offered by the Behavioral Health Administration for specific and defined populations. But again, really, this is where level 1 services are completed by comprehensive community behavioral health providers, essential providers, and the independent network providers. If we go to the next slide to talk about care coordination, this is where needs get a little bit more acute. Level 2 care coordination addresses the complex needs requiring multiple partners across sectors to work together as a team with the individual and the family. There's a care coordination team that provides dedicated support through a trusted relationship or trusted relationships. If we go to the next slide, I'll just summarize what is in care coordination level 2 services. Care coordination level 2 services, not surprisingly, obviously includes everything in care coordination level 1 services. It also expands to include a comprehensive assessment of the person's needs, includes outreach and planning to ensure that we were able to get the support that the person needs. And it also includes coordination with cross-sector partners. That's the best way to describe care coordination level 2 services. These services must be done or provided by a comprehensive community behavioral health provider. These services could be provided by essential providers who are approved or those who are in the independent provider network who are approved. So again, these services must be provided by a comprehensive community behavioral health provider and could be approved by essential providers and those in the independent provider network if they are approved. If we go to the next slide, and finally, we'll talk about level 3 care coordination. Level 3 addresses the most complex and acute needs that usually require multiple partners across sectors working together as a team to make sure the person and the family have the support that they need. If we go to the next slide, not surprisingly, level 3 care coordination includes those activities that are listed in levels 1 and 2. It also is the most high-touch, high-intensity approach to make sure that those with the most acute needs and serious mental illness have the support that they need across multiple systems. Similarly, this level of care coordination, level 3 services, must be done by a comprehensive community behavioral health provider. They could be done by an essential provider or one who is in an independent provider network, as long as they are approved. And that's part of our licensing and rule work that we have been doing. If we go to the next slide, just to kind of summarize the providers of care coordination by level. This is defined within rule as part of the behavioral health entity license. I know that our Quality and Standards Division Director, Tom Miller, put a link to the proposed rules in the chat. So definitely encourage you to check those out if you've not been involved with that process at all. And I know Tom's information is in there as well. So Tom, thanks for making yourself available. We've got the comprehensive community behavioral health providers who must provide level 2 care coordination. Level 2 can also be provided by essential safety net providers and the individual provider network, including primary care providers, as long as there is approval from the BHA. And then comprehensive community behavioral health providers must provide level 3 care coordination. These level can also be provided by essential safety net providers and the individual provider network, including primary care providers within the BHA, with BHA approval. The role of the BHASOs, really, as we've said previously, is to establish a network of providers to ensure that all 3 levels of care coordination are available in their region and in various communities across the region. BHASOs will also be responsible for providing care coordination and making sure that people are connected to the services that they need with a warm handoff. Next slide. This is just another summary of care coordination roles and responsibilities. Again, care coordination level 1, the basics are provided by all of our safety net providers. Care coordination levels 2 and 3 are provided by approved safety net providers. Care navigation is provided by BHASOs. And then the BHA will get involved when we have complex multi-system cases that are escalated under defined circumstances and for defined populations. So wanted to make sure that we have a summary of the different roles and responsibilities across care coordination. If we go to the next slide, one of the questions we've been getting quite a bit is how do we make sure that we're embracing the no wrong door policy? We want to point out that per what we heard from stakeholders, people should be able to access care coordination and services through a variety of ways. Certainly ownpath.co, that is our online care directory that we launched over the summer. We are continuing to strengthen and enhance our online care directory. But if people were reach out to ownpath.co, they will be directly connected to their BHASO should they need assistance with care navigation. People will also be able to contact a BHASO by phone or online to ensure that they're connected to care coordination. We're currently exploring how walk-in centers can be part of care coordination so that people can go to a place in person and be able to talk in person and meet with someone to discuss a plan. And finally, of course, care coordination will be provided by providers as well. If we go to the next slide. We have gotten a lot of questions around how the BHASOs and the RAIs will work together when it comes to care coordination. I will share with you that anyone who is Medicaid eligible or a current Medicaid member who reaches out to a BHASO will be connected to their appropriate RAI. The RAIs will continue to be responsible for providing care coordination for people who are Medicaid eligible. What I would also want to say is that the BHA and our friends over at Healthcare Policy and Financing are continuing to work together to determine what's the best way to utilize our expertise, both within the RAIs, the expertise that we'll have within the BHASOs, and really make sure that we're leveraging our collective provider network to meet the needs of anyone who has a behavioral health issue or need, including care coordination. So there are continuing conversations between both the BHA and Healthcare Policy and Financing, or HCPF, to make sure that we are in alignment in terms of care coordination and how we will work together. If we go to the next slide. I want to ask, finally, before we open it up for questions, what does accountability look like? We know that, again, outside of access to services, probably the biggest desire that we heard from people across Colorado when the governor's behavioral health task force was meeting is that people want a system that is more accountable. Statute requires that the BHA establish a performance monitoring system to track capacity and performance of all of behavioral health providers by July 1st, 2024. So when the BHASO system, when the safety net system launches in July of 2024, so will a performance monitoring system. We are responsible here at the BHA for setting minimum performance standards that address a bunch of key metrics, including, but not limited to, accessibility of care, availability of services, timeliness, and quality care, most importantly. We are working with our friends very closely over at HCPF to make sure that we establish data collection and reporting requirements that are consistent both across the RAIs and the BHASOs, and to make sure that we have a standardized expectations in place. So that is really what's going to be included in our performance monitoring system. Many of you have also heard us talk about our methodology to measure access to care across all payers. This is something that we have been working pretty hard on over the past year and a half. To our knowledge, we have not been able to find a methodology in any other state across the US that has been able to figure out how to measure access to services across all payers. We have started to develop that methodology. We will be starting to pilot that soon. And that too will play into the accountability and ensuring that people have access to high quality services. As we have done for the last couple of years, and will continue to do, all of our partners and stakeholders will be invited to co-create the performance monitoring system so we can hear from all of you what you want to know from that system, what we know in terms of outcomes instead of outputs, and really making sure that people's lives are enriched because of their interaction with the behavioral health system. And we certainly welcome your partnership in helping us to develop that performance monitoring system. Okay, with that, I think we are going to move over to questions. We go to the next slide. I have not been able to monitor the chat box, so can I check with my colleagues over at the BHA and see if there's any themes or maybe clarifying statements that we need to make before we open it up for questions?
Summer, I have many questions. I know Dr. Medlock tried to answer some right in the chat, but I can just kind of start from the beginning if that's okay, unless Dr. Medlock wants to make additional overarching comments.
No, Marina, just guide me on how I can be helpful here. Thanks.
Okay. All right. So first question that started at the beginning of the care coordination conversation. And the question is, how will the care coordinators embedded in different organizations be expected to coordinate with one another?
Absolutely. I tried to express in the chat kind of how we're thinking about the behavioral health ecosystem with our health IT division, but I would be remiss if I didn't acknowledge our health IT division director, who I believe is on the call. Is Kristen Laura able to describe what we're thinking in terms of infrastructure from a technology perspective?
I am, and I'll do that very quickly, very high level. There's a lot that gets packed into this, and a lot of this has to do with how care coordinators work with one another that may or may not be related to technology. So first, as Summer mentioned, we're really centering first and foremost on ownpath.co. We are working currently to add and build upon that in terms of the numbers of providers who are available or accessible on that, including providers who provide whole person care. So not just specifically thinking about clinical services provided in a behavioral space, but also services responsive to housing as an example. So that there is a centralized space in the state of Colorado for care navigators and care coordinators to identify what services are available within their community or what services are available to an individual. Oh, is it hard to hear me? Hello?
Yes, it's a little muffled, so you want to be closer.
Is it easier now? I don't know what microphone it's going to.
Yes, that's good.
Much better.
Okay, I'm gonna turn off my camera so you don't have to look at me weird. Okay, so sorry about that. I will start over. So we have ownpath.co, which is where providers are accessible or available, their information is available. There will be an opportunity or availability to an individual person in Colorado using that site to seek services, to reach out to their BHASO or a BHASO to receive navigation support. In addition, we will be embarking on a referral research and discovery or planning project sometime this spring, which will hopefully inform how we support and streamline care coordination between providers, to the question that was asked earlier around how do we ensure, facilitate care coordination between providers. We also expect that we will lean quite heavily, at least in the initial implementation phase, directly on BHASOs to help us make sure that we are identifying where needed, and this is primarily in levels 2 and 3 for care coordination, the dedicated focal point for an individual and who is coordinating their care. Care coordination at level 1 is more diffuse in the system and will be served, I think, more primarily by care coordinators leveraging the OwnPath site in particular. I'm going to pause there and turn it back over to you, Dr. Medlock, in case there's anything that I jumped over. Now, having said that, I am going to comment that we are also collaborating very closely with the Office of eHealth Innovation, who will, or hopefully will have a contract in place to begin implementation of social health information exchange infrastructure. That will start in July, ideally, or that is the goal. And we are partnering very closely with them on those particular connection points. Now, I think I'm going to turn it over.
That's great, Kristen, Laura. And I would just add to that, someone in the chat was mentioning the social health information exchange, and that is a priority for the state to have that ability and that infrastructure built to support a comprehensive care coordination system, not just within the treatment continuum, but within the social services continuum. All right, Marina, what's next?
Yep, thank you. It would be nice to have both parents' participation in the coordinated care of their children. Oftentimes there is a primary caregiver and the absent parent is not obligated to be responsible and participate in the care coordination of the child. I think this hinders the outcome and would love to see some language included in custody agreements that addresses this issue.
I think I answered that particular question. And so if that person could just pull down in the chat, did I answer that one, Marina?
I didn't see it, but maybe I could have missed it too. So hopefully
Okay.
let us know if we missed it, the person who asked that question. Meanwhile, we'll move to the next question if that's okay. And,
Yes, go ahead.
And the question is, please account for the many SDOH screening tools that are already in place and the complexity involved in moving to one screening tool, EHR interfaces training and training that has already taken place around those screening tools.
Thank you for that. Our chief data officer is onboarding, and his philosophy is that we should really be supporting data metrics that are able to be collected. We shouldn't be really complicating new tools, screenings, et cetera, that only provide burden across the safety net system. So we're first interested in working with our providers to understand what's already been collected and how we can align with that as we build a people-first performance system.
Thank you. Next question, will the BHASOs contract with CCBHPs for non-Medicaid safety net services on a capacity/program basis, or will they be reimbursed by services provided? In parentheses, encounter-based.
Let's see. Can you repeat that question? I'm sorry.
Yep. Will the BHASOs contract with CCBHPs for non-Medicaid safety net services on a capacity/program basis, or will they be reimbursed by services provided? Encounter-based.
I'm going to go to my finance folks on this one. So Summer or Stephen Pang, our chief financial officer.
Stephen, I'm going to check in with you to see if you've had conversations with your team about this.
No, the exact payment provisions between the BHASOs and subcontract providers, I think, are still being worked out right now. But it will be a model where we utilize, in certain situations, reimbursement by fee for service or reimbursement in the capacity model. So those themes will carry forward through the BHASO implementation.
Thank you, Stephen. Next question. What is the plan to ensure we have enough workforce in the care coordination? And I believe Dr. Medlock said that we have workforce strategy in our strategic plan laid out. Let's see here. Next question, if I may. Douglas County operates an enhanced care coordination program for multi-system involved complex need individuals. The care compact in collaboration with 10+ community partner agencies, hospital, CMHCs, RAISE, co-responders, human services. Could the county contract with BHASOs Could the county contract with BHASOs? And if so, would the county need to be licensed as an essential provider? Would it be sufficient if one or more or the partnering agencies had an essential or comprehensive designation?
I think I answered that one also, but I may also go to our fiscal team here to provide clarity. Maybe I was unclear. So Summer or Stephen want to tackle that fiscal question there? I thought I answered that one, but go ahead.
I actually want to check in to see if Tom can help address the licensure question.
Thank you, Summer. If I understood the question correctly, I believe that the provider in question would need approval as a safety net provider and not necessarily a behavioral health entity licensure. But feel free, and I missed who asked the question, but that person should feel free to reach out to me directly.
Thank you. Next question. How will the state pay for non-Medicaid clients for care coordination? I understand you're working with HCFA for Medicaid clients, but feel like the regulations and proposed payment for care coordination services should be presented at the same time. One cannot happen without the other.
I can speak broadly to the vision of the BHA, which is cross-payer and obviously much broader than the safety net. We were really called to be an agency that establishes standards, period, for the behavioral health system, and then have those standards align with obviously our public benefit in Medicaid and also our commercial market as we collaborate with the Division of Insurance. So that is the larger vision. The BHA does have a formal agreement that is nearly complete with the Division of Insurance, and that's how we intend to influence and leverage these standards within the commercial market. That's a high-level overview. I wonder, does that address the question?
I think
Dr. Miller, I'll just join in. Oh, Lauren, go ahead.
No, go ahead, Summer.
I was just going to say at a higher level, and I'll check in with Stephen, our CFO, to see if he wants to add anything else, but we have been undergoing the full financial analysis to understand the cost for all of these services and how they will be covered. And so that's not something we have ready to share yet, but it is something that we have been working on. Stephen, I don't know if there's anything else that you would want to add.
Yeah, it just pretty much along those themes as part of that financial analysis. It involves kind of determining funds available for care coordination, specifically to address the question.
Do you know when we expect to have that information? I'm just wondering, like the IPN and essential providers for non-Medicaid clients, how are we expecting to pay them, but also expect them to meet all of these regulations? They seem to go hand in hand. So just wondering about timing and when the rules pass.
Yeah, I have to say, I'm not sure I can share the timing yet. I can just tell you that we're having numerous internal conversations to work through all of that. So hopefully in the near future, we will have some more information on it.
There's a clarification question in the chat, if I may, and it's from Frank. Just to clarify your comment above, reference own path. Are you saying people will be attributed to the BHASO, or simply that they can identify the BHASO responsible for their region on the own path side?
That's a great question. So although we have articulated in this presentation that obviously a person is not going to be restricted by their location, their primary location or where they seek shelter will guide their initial point of entry into the system, if that makes sense. So you'll notice that OwnPath first asks you, what zip code are you seeking help in? So once the person clicks on the banner that says, I'm seeking a guided experience, then in our future state, that will ideally connect the person to the BHASO, connect it to the zip code that they requested. I hope that helps.
Thank you, Dr. Malbach. And last question that I see here, how will the BHASOs determine if someone is Medicaid eligible? Currently, the RAISE will not provide care coordination unless a member has active Medicaid.
We do want to emphasize that our work is so closely tied to healthcare policy and finance, and that neither the BHASO nor the RAE should be existing in a silo. They're coordinated, they're working together, and that's the ideal system. So those decisions will be made collaboratively, and someone who is Medicaid eligible or a Medicaid member will be supported through the RAE.
Thank you, Dr. Medlock. One last question, I believe, that just came in. Given that OBHBHA has not previously paid for care coordination, will the funds for the newly covered service be carved out of the existing funding for services, or have new funds been approved?
Thank you for that. There were a number of bills last session that did provide resources for care coordination. In addition, our Chief Financial Officer is evaluating how we align with federal strategies for funding care coordination. And I wonder, is our policy director on the line to just clarify some of those care coordination resources that are provided in legislation?
Yes, Ryan Templeton, Policy and External Affairs Division Director. So there was some care coordination funding from House Bill 22-1256. That's that involuntary mental health bill, or the updates to the 2765 system that provided care coordination funding for individuals involved or court ordered for certification, as well as there's the care coordination infrastructure bill that had some care coordination specific services and for navigators and care coordination through 177, and as well as Senate Bill 21-137, which set the foundation for the care coordination infrastructure. So those are really the three big pieces of legislation that had new money for care coordination specifically.
Thank you, Ryan. I believe that's all I have, actually.
All right, if we go to the next slide, we will just wrap things up with the 90 seconds that we have left. Just to let everyone know what happens next, we are continuing to listen to all of you. Hopefully that was clear today, that some of the work that we've been doing, the changes that we've made have been a direct result of the feedback and the input that we've gotten from all of you. We're continuing to listen. We're continuing to analyze what's best for the people in Colorado with the resources that we have available. Appreciate everybody's questions today. Every single question helps us think a little bit harder and longer about how do we make sure that we develop this system together in a way that really does meet the needs of everyone in Colorado. As to reiterate, the RFP will be released later on this spring. Procurement rules don't allow me to say any other details beyond that, but you can keep an eye on that. And if we go to the next and final slide, that QR box right there will take you to our webpage. Definitely encourage you to keep an eye on our webpage for updates. Keep an eye on our webpage for upcoming stakeholder engagement opportunities. We have a variety of huge initiatives going on right now and lots of different stakeholder meetings. So please visit our webpage and any updates will be posted there as well. We really appreciate everybody's time and conversation today, and we look forward to continuing the conversation with all of you. Dr. Medlock, any final words before we sign off?
Yes, I also want to thank everyone for being here today, but let's close this question in the chat about how to provide feedback. Can we guide the people of Colorado on that before ending today? Is our general email account still open? Let's just provide some guidance on that.
Yes, best way to provide feedback is through our general email account, which of course is escaping me right now. Let me see if I can track it down and we can put it in the chat box.
Okay, thank you. That is the role feedback. If one of our division directors would kindly pull our general email feedback from our Contact Us page, and let's put that in the chat before we end today. It should be on the Contact Us page of the BHA website. Yes, that is correct. That's the one I have, cdhsbha@state.co.us. Thank you, everybody.
Thanks, everyone. Again, appreciate your time today.